And we continue to the next speaker. Mahdieh Khanmohammadi is associate professor in signal processing at the University of Stavanger. She has her Master of Science in Medical Imaging from University of Tehran and Master of Science in Computational Engineering from Halmstad University in Sweden. And her PhD in Medical Data Analysis from the University of Copenhagen in Denmark. And Mahdieh is going to talk about from segmentation to prediction, AI methods for stroke imaging analysis.
So I'm a fast speaker, so that should not be a problem. Well, thank you very much to SAIL, UIS, and Noura for this event. My name is Mahdieh Khanmohammadi, as Tom tried to say it correctly. I appreciate that. Today I'm going to talk about this topic, which is from segmentation to prediction, AI methods for analyzing stroke. And this is actually a work of many that I have the privilege to present it. Well, imagine a person that suddenly loses his ability to talk or move one part of his body. Then this is a case of a stroke, and this person is supposed to be rushed to the hospital for analysis and advice, medical advice. There are many different subtypes of stroke. It can be actually due to this one blood cell being ruptured in our brain, and there's a bleeding. We call them hemorrhage. There's another type, which is actually some part of the brain vessels, they are narrowed, so they actually prevent the oxygenated blood from moving. Also, there might be actually a large blood clot that has gotten stuck in one of the vessels in the brain. So that actually makes a blockage, preventing the oxygenated blood from moving to the brain cells. And that is actually what the topic of today's talk, and we call them ischemic stroke, as you see this here. When there's not enough oxygenated blood, then some part of the brain tissue starts to die. When this patient is now arrived at the hospital, then this is a task of neurologist, neuroradiologist to diagnose this stroke, where is it happening, and there are so many things that they are supposed to consider for that. And they have to tailor this treatment for this specific patient based on all of those things that you saw before and make a decision there. They have a very short window of time because as the minute goes by, many of those brain cells start dying and dying. So we have to act very fast. Well, they have to act very fast. This is as opposed to like cancer diseases, which is a marathon. The doctors, they can come and revisit their treatment plan after some time. This is like a 100-meter sprint. They have this golden time window, which is about 4 to 5 hours from the onset of a stroke. And it takes time to bring the patient to the hospital, so they don't know actually when that has happened. So they want to actually make best out of that. So to summarize, this is the procedure. Stroke happens, they send an ambulance, they bring the patient in, then they actually start doing this radiological workup, which they, at the University of Stavanger hospital here, they actually start with the CT, and that is the case in many other hospitals as well, because that's much faster. So they do a whole bunch of CT images, either with the contrast agent to illuminate the blood vessels or without contrast agent. Then they start looking at these, I don't know where, oh yeah. They start looking at these images, which is a very comprehensive data, and then after all, they have to make a decision fast under all of this pressure. They want to make a decision either to give the treatment or don't give the treatment. The treatment is very expensive, but that is not the reason to avoid that for many patients. The other reason is that if they give the treatment, they may actually keep the patient alive, but they will end up as a vegetable on the table. And that is not an outcome that we want. So then, even if when they decide actually to give the treatment, this is the treatment. Either they inject the patient with a drug that will actually soften the clot, it will go away, disappear, or they have to mechanically go in with a wire and fetch the blood clot out and remove the blockage. So it's called thrombectomy. After that, they run this MRI protocol to see how well they have done. which part of the brain has died or not. So when we asked, how can we use AI to help them in this procedure, make this faster? The very first thing came to mind, it was like, why not using AI to study this comprehensive image data to come up with this dead tissue, the tissue that is going to be dead if we don't act fast. And another part was actually, okay, now we have these damaged tissues that we know that they are there, we have segmented them. How can we relate that to the part that is actually finally, even after the treatment has died? Can we actually come up with this prediction? If you, from these initial images, can we come up with the prediction of like, okay, if you do even the treatment, this part of the brain will still be dead? So as I said, we have so many data that has come to us, like so many things that we've been captured at the hospital admission when the patient arrives. It's a non-contrast CT for the whole head, it's an angiography, when they will see actually this is hemorrhage or this is actually blockage. This is a blockage case, so it will even come to this study. And this is a CT perfusion, which is a 4-dimensional data. They take it from one slab of the brain, not the whole brain, specifically where the stroke is. And then they capture these images while there's a contrast agent moving inside our blood system in the brain. So they can study the hemodynamics of the blood flow. And from this, they get these parametric maps, which talks about the hemodynamic of how blood actually moves now in this patient, for example. The flow, the volume, the time, etc. And then after treatment, they do this MRI protocol. They capture DWI, diffusion-weighted images, the ADC maps, FLAIR, MR angiography, etc., etc. The most common one is the DWI, which I'm going to talk about that too. Now we are focusing on this part, which is the CT perfusion. So I want to define these 3 regions. We have, when the stroke happens, there's some cells that are already dead when that happens. So those are core, and they are shown with red here. And there's another one, which is penumbra, the tissue on the surrounding of that is actually viable. It is, if you don't do anything, it will end up being dead, but it is still viable. And then in the MRI, we have this final infarct, which is gone. But it's okay. With some rehabilitation, the patient can have close to normal life in many cases. So we thought, okay, let's do this automatic penumbra diagnostic. We have the CT information, we have all comprehensive data there, 4-dimensional data, and also derived parametric maps from it. We have NIHSS score, which is about how severe the stroke is, and then using AI to segment these 2 regions. To the best of our knowledge, we are the only group doing this. Everybody else, they are segmenting from even CTP, the final infarct, not these 2 intermediate state regions. This is the work of our former PhD student, Luca Tomasetti. He developed many different supervised and unsupervised deep learning techniques and different combinations of input and the 2D segmentation output. 152 patients were in this study, and we compared our method with many other techniques that there were, and we are proud of that. So the segmentation task was okay, but then that's not the only thing that we wanted to address. We wanted to address like what happens next. Now we have this segmentation, and then how can we actually how can we connect this tissue at this time point to the final infarct tissue? So this is a penumbra diagnostic. If you take a look, this is a perfusion maps, and these are the diffusion maps from the MRI. If you overlap these 2, there will be actually a mismatch between them. So if the mismatch is great, then this case is a good candidate for therapy. This is case 1. It's not a good, there's a good match between them, not a good candidate for therapy. And this is a very big mismatch, so this is a good candidate for therapy. So we thought, okay, we have these data at the admission time from the CT perfusion and the color maps there, and we have the DWI regions. Let's try to make a connection between these 2 by studying these different regions. These are different modalities. As I said, CT perfusion comes from a small portion of the brain, not the whole brain, but the MRI actually is captured from the whole head. So we have to do this pre-processing for modality fusion to be able to analyze them. So this is a 4-dimensional, first of all, and then this is studied over time, so we can actually produce this 3D color map. Okay, that problem is solved, but still, this is much smaller in the Z dimension compared to the DWI, so we have to find those slices of the brain that they are existing, that are corresponding to the DWI. So we find them, and we actually do the registration for the head tilt, movement, etc. And then we do this overlay. And now this is 152 patients, 43 didn't have MRI, and we actually included only the ones that they had a large vessel occlusion compared to this one. And there were 61, 48 they were recanalized, they were treated, and then the 13 they were not recanalized. And these are the results. Here I'm actually talking about the cerebral blood volume as opposed to the transient time coefficient variation, which is COV. And the 3D plot here, the height shows actually how many of those combination of CBV and COV we have there. And then the color actually shows the probability of ending up as a final infarct region. So when you look at this, this is actually the recanalized or treated patient as opposed to this one, which was not treated. So there are so many combinations of those many areas of the penumbra that they are showing like high probability of dying. And then here, as in, if you compare this with this one, very small portion of like around CBV of 1 milliliter per 100 milliliter of the brain, they are showing a high probability. So this is actually our future work. This is unpublished, and we are going to work on this furthermore. With this slide, I would like to end, and thank you for listening.
Thank you so much. Question, anyone? And please repeat the question if you get any.
Yeah, so thanks a lot for the presentation and for naming as well. Glad to have you here. I was just wondering, so you have shown a bit the steps, and maybe you could explain a bit what's the, ideally, what would you like to get out of all of this? Do you see a medical device, something that you could give to the radiologist? Who would be the target group, and how would you imagine this working? Yeah, anything.
Well, actually, I'm not a device, but as the former speakers, they also mentioned, like a software that can help with this segmentation, because it's a tremendous amount of pressure on the doctors, and this is a very comprehensive data to look at and make a decision. So we would hope for this software that can predict at least something for them.